Hi, my name is Anika Zedi, and I'm a second-year internal medicine resident at Mercy Health Hospital, Rockford, Illinois. Today I'm presenting a case with the title, A Sweet Complication of Immune Checkpoint Inhibitors. So, the cause of type 1 diabetes mellitus in adults has been recognized to be multifactorial. And we know that with the advancement of cancer treatment and frequent use of immune checkpoint inhibitors, including the combination therapy with anti-PD-1 like the nivolumab and anti-CTLA-4 ipilimumab, there have been reports of autoimmune associated diseases and diabetes. So in our case, there is a 72-year-old female patient who presented to the emergency department after her oncologist noted her to be hyperglycemic with a glucose of more than 700 on routine labs. The only complaint she had was polyuria with increased thirst for the past 1 week. Her past medical history does include hypertension, Brenner tumor of ovary, and she's status post bilateral salpingo-oophorectomy. She has a history of asthma and active stage 4 non-small cell lung cancer. So she was diagnosed with non-small cell lung cancer, the adenocarcinoma subtype, 5 months ago and was started on double immunotherapy with nivolumab every 2 weeks and ipilimumab every 6 weeks. Her most recent infusions were on the day of the presentation. On presentation in the ED, she was hemodynamically stable and her physical exam was unremarkable. So the hospital course included the lab workup, which revealed that the pH was slightly on the lower side, 7.32, showing acidosis with a normal bicarb level. There was no anion gap and lactic acid of 1.9. Beta hydroxybutyrate was 0.40 millimoles per liter, sodium of 125, potassium 5.2 milliequivalents per liter, and the initial blood glucose of 731 milligram per deciliter. Her current A1C was now 9.5% compared to 4.9%, which was 5 months ago. C-peptide was low at zero point 0.4 nanogram per milliliter, suggesting type 1 diabetes mellitus. So her newly diagnosed type 1 diabetes mellitus was with profound hyperglycemia, was treated with hydration, monitoring and replacement of electrolytes, and insulin drip. Eventually, she was transitioned to the subcutaneous insulin as blood glucose normalized. So upon discharge, she was diagnosed with adult onset type 1 diabetes mellitus, and she received education and management of diabetes, discharged with insulin, and an endocrinology follow-up. So, what we want to discuss here is that with the increased use of ICI therapy, the immune checkpoint inhibitor therapy, including the anti-PD-1 nivolumab and anti-CTLA-4 ipilimumab, physicians and patients must be aware of the potential medical issues that may arise. Anti-PD-1 monotherapy or a combination of agents may precipitate autoimmune disorders by modulating immunologic tolerance. Furthermore, immune checkpoint inhibitors may cause fulminant diabetes as a result from immune attack and destruction of pancreatic beta cells, and can thus present as type 1 diabetes mellitus with a rapid onset within few weeks after starting the immune checkpoint inhibitor therapy. So our conclusion is that ICI-induced type 1 diabetes mellitus could be a medical emergency and may proceed to diabetic ketoacidosis quickly if not promptly recognized. In our patient, we present a case of new onset type 1 diabetes mellitus after the initiation of dual immunotherapy. As these therapies are becoming more and more common, we recommend physicians have discussion with the patients of the potential side effects prior to the treatment and stay vigilant because it can result in patients getting type 1 diabetes mellitus. Thank you.